Vi går nu over til vores gæstetaler. Det er et indlæg, der vil foregå på engelsk, og vi har i år valgt at invitere Hal Wolf, som er vicepræsident i den verdensomspændende organisation HIMSS, som arbejder for bedre sundhed ved hjælp af IT. Hal har arbejdet med det her i mange år, blandt andet også været direktør i Kaiser Permanente i en del år. Og noget af det, han vil komme ind på, er den hastige teknologiske udvikling, hvordan det vil påvirke fremtidens sundhedsvæsen, og ikke mindst også, hvordan den nye sundhedsforbruger vil være kritisk i sin efterspørgsel og efterspørge nye former for sundhed. Hal vil tale i cirka en halv time, og så vil der være mulighed for nogle få spørgsmål efter oplægget. So, Hal Wolf, please come to the stage. The floor is yours.
Thank you so much. We should note that Adam and I are not related. Maybe third cousins, I don't know, could be. It is a pleasure to be here, and thank you so much. This is an honor, it really is. I've been traveling and being in Denmark for many years, about a decade now. So a chance to be in front of you and share some thoughts on digital health and consumerism, where things are going, is really special. So we're up and running. Our time will be precious, and I'm going to go at a pace that I hope we will find both energetic and the translators can keep up with. And they did a brilliant job yesterday as I was listening to Sophie and many of the speakers and hearing their points. See, we get our first slide. There we are. Many of the themes that you have been discussing are similar to the same challenges that are facing healthcare systems across the globe. We're dealing with an aging population, the silver tsunami. I'm in that crowd. We're coming up and going to take a giant wave coming into healthcare systems in every single corner of the world. We are going to be bringing high chronic diseases with us and burdens. Fortunately, I'm not in that camp, but time will tell. And we are dealing with geographic displacement today. And geographic displacement is not just, is there equality with rural areas? It happens inside urban areas as well, because we can't build hospitals fast enough in sprawling urban centers. Sometimes we don't have enough space, and frankly, the capital demands are huge. And we all deal with extremely complicated funding systems. And if you have any question about that on the US side, you would read the papers and recognize that we have a few issues going on in the US about funding for healthcare. Yeah. Before I go any further, I should probably note that I did not vote for, support, or can really tell you what the design is of the Trump administration, but we'll come back to that at some point. And then finally, you're dealing with a highly educated consumer. And this is really one of the points, and I've heard this brought up a lot in the last day and a half. What is going on with the consumer? Is it important? Is it not important? And we're truly going to be focusing on that. And so as we think about all of these issues and we think about that demanding consumer, we need to put it within the context, first of all, of the challenges that are hitting hospital systems. And again, this is a global issue. Now, these are the 10 that popped up across 1,000 hospital leaders. And we'll talk a lot about the acute setting and the medical model, if you would. But financial challenges, not unique. Government mandates that are putting more and more burden on the provider systems to produce greater quality, greater outcome, lower cost. Patient safety, extremely important, with greater understanding and measurements of this space. Personnel shortages, patient satisfaction, access to care. We talked about the geographic displacement. The physician, the hospital relationships, stressed potentially more now than at any other time. And population health management, a commitment to the use of data and information, the technology itself, and frankly, the reorganizations of hospitals, even here, impacting as you consolidate and you go to different and new hospitals and taking some offline to come to more centralization. And all of this is being done in a financial model that is very challenging. So this is 2 slides we're going to look at. This is just expenditure per capita using US dollars. And you can see that Switzerland and Norway have displaced the United States on a per capita basis, not in GDP, but in per capita, which is quite interesting. And you can see that Denmark, and this is World Health Organization information from 2 years ago, is coming in right at number 5, which is roughly at this time around $6,500 per person in capita, against a mean and an average of roughly around $4,300 per year. So your expenditures per person are above average. You're getting great results, but above average, right? And then you go to your funding model. And you have to recognize that the funding model, of course, varies. But when you take a look at the percentage of your healthcare expenditure, which is paid for by your actions from a government point of view, you can see that you're in that 85% range of every dollar spent in healthcare is government funded. Now, the US doesn't actually have a healthcare system. It's a mishmash of many different things, which is why if you looked at the US number, it would be sitting at 48%, and that is largely Medicare. So in your own domain, you have a pretty solid investment per person, and you are fundamentally absorbing that cost at a very high level from a government expenditure standpoint. And all of that goes against a piece of information we talked a bit about yesterday, but it's worth bearing. Currently in Denmark, like everywhere else in the world, the number of individuals who are generating the revenue, the GDP, which is necessary to pay for government services, is currently at 3.2 individuals per dependent, and by 2025 will be at 2.3. Those were the stats that we heard yesterday in terms of Denmark's numbers. And so what you're seeing is that silver tsunami. You're seeing this big hump in population growth, and then on the backside of it, fewer people to be able to pay the bill per country. And so regardless of the financial stress that we have on an individual person now, and no matter how we take our approaches to change the cost curve, recognize it's not going to go away. In fact, I would argue over the next 8 years, it may well accelerate. And that creates risk. And that risk falls, as you know, in a hard game between the national level, the regional level, the municipality. Acute settings and facilities have to think about the impact, and of course, all the way down to the provider groups. Because the doctors, in many cases globally, are beginning to have to assume some level of risk, and we may call it value-based care, where they're absorbing risk based upon the actual delivery, but it's risk nonetheless. And how we handle that risk over the next 10 years, very powerful, very important. So, digital health, consumerism. Let's just go through a very, very basic definition, and I like to use as broad a definition as my mind can come up with. So this is one of my favorites from John Lewis Carroll, where it means just what I say when I say it, nothing less and nothing more. So for the sake of our discussion on digital health, we're going to assume the broad definition of telehealth, telemedicine, mobile health, virtual health and care, biomed devices. We're going to take a large pathway when we think about the digital domain and how we apply it and how it's being applied into healthcare. Now, for sake of that definition, the healthcare settings that I'd like to talk about are within these 4 areas. Primary prevention, keeping people well, and keeping them well as best we can from day one. Secondary prevention, something has occurred, we don't want to relapse, we're going to keep them. It could be therapy after an operation, it could be many things, but secondary prevention, let's stop it from occurring again. Our classic acute care, what is happening in the hospital, and then in a special category, chronic care, because it cuts across multiple planes of secondary care and acute care. And as we know, our frequent flyers are consuming 80% of the resources, 10% of the population, roughly, 80% of the resources, and that is fundamentally universal, give or take a few percentage points. And how we deliver care is critical and becoming more and more complex. Now, if we go back and we think about basic, traditional primary care, one patient, one doctor, you've known them all your life, they've known you, they may have known your family. Certainly in the small town I grew up in North Carolina, the same doctor that took care of my parents took care of me, you know, and Mark's finally retiring this year, and we all knew each other, we knew the family habits, etc. And really that was the total domain of your healthcare experience unless there was something that happened that drove you to the hospital. But as populations have grown and we've become far more understanding of the chronic diseases, we've reached out with the patient and the primary care and a chronic team to recognize that one individual trying to care across a chronic disease team, very hard to do. We begin to hear this word team to take care of folks. And here in Denmark, the primary care medical home gets pushed a lot because you're so primary care centric in your starting place. And it's an important part of that team, but the medical neighborhood and in the end integrated care is fundamentally where many systems are going, and I know you have initiatives that have been looking at that and pushing it as well. And that takes a different bridge, because even from the primary care medical home and pushing to the medical neighborhood, you begin to see the use of information, multiple teams, and multiple settings. And it leads us to this point of integrated care. And the goal, excuse me, and the goal of integrated care being to get to the right patient. Sorry, I get choked up over integrated care. The integrated care of really getting the right patient at the right time to the right person to take care of them, like now. And you have a shared commitment about functional and structural funding, and you begin to think about not my setting, but the way in which the patient has to go fully across the care setting. And it really just gets back. Right place, right time, right care for that patient at any given moment, right? From an integrated care model, if the doctors are finally looking at one chart, one piece of information, and they're collectively thinking about it, and that's inside the ICU, we've failed, right? That's not the place that integrated care needs to take place. It has to take place long before. And from a patient's point of view, this is what they're looking for, right? Who's going to be taking care of me? Now, let me introduce you to a couple people in my family. This is absolutely one of my favorite pictures. This is Bandit on the left. Okay, he turns 15 this month. And to the right is the other Adam Wolf in my life, who's my son. He was, that's right. You knew it, right? You knew there was a connection. And Adam is now 22. And this is actually the moment that the two of them met for the very first time, right? And I just happened to have the camera, and I was watching this puppy. And interestingly enough, there were two puppies, and then Bandit came over. The other one kind of wandered off because he wasn't interested. And then the magic occurred, and you can see it in their eyes, and I adore this picture. Now, this was 15 years ago, right? And here's the question that pops up with this picture. Which one of these patients had a patient registry at the time the picture was taken? Which one had a doctor that knew the immunization schedule of their patient, sent notices as to when the immunization needed to take place, made follow-up phone calls to make sure that they came in? I'll give you a clue. It was the one that needed heartworm medicine, right? It was the puppy. The puppy had a system behind him where the doctor was proactively reaching out in what we would call basic population care management against standardized practices for puppies. But that didn't exist at the same time for my son. Kind of weird, right? So this is one of my favorite pictures also, and I will just simply tell you I'm cheating a little bit, because probably at the end of this talk, the only thing you may remember is this picture. And that's okay, all right? So this is what's happening. This is the medical model, which is using information, and we are developing it in our hospitals and in our acute settings. And this is about the population care management, which is frankly mass targeting, right? We have national targets, basic demographics, and all patients are plugged into it. But there is an entire piece we've learned in population care about subsegmentation. And do they have other medical conditions? Just because a woman may be 50 years old plus does not mean they should automatically have a mammogram every 2 years. That should not be the call, especially if they're undergoing cancer treatment already, or we are aware of other medical conditions and where that should not be the case. It can actually be traumatic to send a notification. And patients have preferences about where the care should be delivered. And we are on the forefront of delivering genomics. So all of this is driving towards personalization of care to the individual. And we see it every day in the systems we're putting together and how we refine our care pathways. And that's great. But there is a problem. And there is a catch. And it is the consumer. Because the consumer is not waiting for the medical system to catch up to their demands. They are interested in their personal data. They're interested in their personal diagnosis. They're interested in their own preferences and their own behaviors. And believe me, and you'll see in a second, the #1 doctor in the world is Dr. Google. And if you can't get in, and if you can't get immediate assistance, and even if you can, and maybe you've done it yourself, and I would actually be surprised if you hadn't, you're looking up on the web and you're taking a look at what's going on in that outside world. So the rush is to bring these two systems together and to recognize that personal care and personalized medicine is fundamentally what we are driving towards. And frankly, we're beginning to trail the consumer who's out in the open. Now, you may say, Denmark's a little different. I'm not hearing about this. we're not really that interested in the digital space. Okay. But take a look at this, because this isn't about healthcare, but this is a measurement of the digital economy and society index. And this piece of information, by the way, is 3 weeks old. This is a brand new survey. It literally just came out. And it's a measurement of looking at 5 data points from a society standpoint. One is connectivity. Is there broadband deployed? Is there Wi-Fi deployed? Can people easily connect? 2, is there a human capital? Is it capable where the measures and the skills can take advantage, right, of the systems that are in front of us? Is internet available? Are people using it? Are they shopping on it? Is there digital technology for digitization for businesses? Can you order things online? Can you bring them forward? Or are you just using outside information to run your shop on a regular basis? Just like the guy with the delivery comes to your home and drops the package, who does a digital sign-off, and seconds later you get a note saying your package has been delivered to your front door. And the digital public services. What can you do online from a service standpoint, from information, billing, obtaining records? These are things that are componentized, and they're looking at the digital society and the economy that's sitting behind it. And here is the EU. And look at the #1 country that is engaged in the digital economy and society index, and it's Denmark. So of every country in the EU that takes these 5 pieces together, you are living in the most plugged in, right? And that's not happening because people aren't interested. That's happening for a reason. That's happening because individuals are taking advantage of the capabilities that are around them and controlling their environment. So when you bring these pieces together, and you think about this from a healthcare setting, these are, in fact, many of the problem statements, and these are 4, but it's incredibly important to point out, to recognize that healthcare is absolutely going under the same disruptive pressures and changes that every other industry before us has taken place. Whether it's banking, transportation, whatever the case may be, healthcare is not immune. And secondly, providers have to be able to connect into the wellness preferences of their patients, because the patients, quite frankly, are going to seek it out on their own. We'll go deeper in a second. And the semi-automatic, cumbersome processes that we've put in place from an institutional standpoint, they don't care. And our access to information just simply has to be better so that providers can take advantage of it. And understand from a provider point of view how much the world has changed. If you go back to 1972, there were 350, on average, peer-reviewed documents per year that were published through 3 major publications. And that was about it. 350. So if you were a diligent doctor, every night you could read 1 article and basically keep up with the demands of healthcare and the changes in it. This year, in 2017, over 4,000 peer review articles will be written and published. It is simply not possible for any single physician, or frankly a small team of physicians, even within their specialty, to know and keep up with every single change that is happening. So people are using what we call extenders. They're out on the net. They get notifications when something has popped up in their specialty, in their domain. They use clinical decision support to support their decisions around clinical data in terms of what should be done next in terms of treatment plans. This is just practical. This is just good, normal care. And as we increase those mandates, as we increase the pressure on quality in the measurements, the need and the reliability on these digital helping points becomes more critical. And so we're creating, if you would, a world of connectivity that really now recognizes that it's no longer just the doctor and the patient. It is all about the physicians, payers in many systems, and by the way, government is the payer. And you're as plugged into those outcomes as any insurance company is going to be, because you're anticipating, just like any actuarialist, how sick is my population going to be, what services do I need to provide, and how do I provide them? And then you're making contracts with your payers, with your providers, to make sure that the right resources are available and how they mix together. And other care continuums start to come into it, whether it's nursing homes, municipalities, whatever the case may be. This is a connected world. It is a new ecosystem. Now, some of you may be thinking that that patient, that person should be in the middle. And they are, and you'll see that soon. But it's a circle, and it flows in both ways. We had a bit of a discussion last night, and you're going to hear 3 different words that pop up from time to time. The patient, which is the individual who's receiving treatment. A citizen, what are they expecting in terms of their rights, regardless of their medical condition? And the person. The person as a whole who's looking up and saying, don't treat me as an object of the state. Don't treat me as a patient. I'm an individual. I need my world to wrap around me, right? And if there's one thing we're learning is we're all kind of needy in this space. And so these are the consumer preferences that are starting to hit us. Now, let's take a look at global demand. Because if you have any doubt about digital health, let's start to understand investment. And there's an old expression, and it's a beautiful one. It says, follow the money, right? You've heard that. You know that expression. And so in the global digital market, the digital health market in 2014 was worth about 29 billion US dollars and expected by next year to grow to 54. Just got a notification yesterday, last quarter, just the first 3 months of the year, $2.5 billion in digital health acquisitions going on. This doesn't include normal investment and trade. This is just systems being bought and applications being exchanged. So this is a market that's going from an application environment of 2,750 back in 14 with over 13,000 by next year. And we know right now there's about 11,500. So can you imagine all this investment going in with everything from supply chain, critically important, to did you take your pill last night, right? And this is outside the scope of what's on your phone, which is just pure consumerism, which now numbers in tens of thousands of apps, with hundreds literally being produced every single day. And people are using this information, and they're using these capabilities, especially online, and there are 3 buckets here. One is knowledge management, and we'll take a deeper dive into it, which is looking information up, whether it's on WebMD. This is from last year, where 50% of consumers have tried it, another 17% are on their way to using it. Mobile devices increasing dramatically in how people are using medical information, and even genomic services, where I can get baseline genomic information, right? These things are happening and they're accelerating. So in these 3 buckets, take a look at knowledge management. Now, how many of you have ever looked and Googled a symptom, a definition, anything, right? I would almost bet everyone. Okay. There was no way that you have not done that. Okay, fair enough. That would be demographically impossible, right? I'm going to force hands. What is going on here? So people are looking up prescription drugs. They're trying to understand their diagnosis. They're looking up supplements. What should I take? Treatment options. But they're not doing this just in retro. They're doing it proactively. Here comes the cool part and the scary part. In treatment options, 49% of individuals are looking up the options based on their own diagnostics. And 36% are walking into their doctor with their own proposed treatment plan. Right? This is Dr. Google. If you don't think they're engaged, and the doctor's looking up and they're thinking, good, bad, indifferent, right information, wrong information, and sometimes I hadn't heard that. Right? And they got to go back and look. People are not waiting. Right? So the knowledge management and the way that the health system has to guide people to the right information and to meet their needs, this is big stuff. And where they can, they're looking up physicians, and they're looking up the hospitals, and they're looking for measurements, and they want to know, am I talking to the right specialist who's actually done this before? Or is it just another person in a white coat? A bit of the mystique is getting taken away. And they're thinking about it in terms of care at home. They're thinking about the fact that 88% that they would value online information, but they'd also rather have it, which is really important, from a trusted source. And people are willing to actually pay a premium in conjunction for this information. And they're willing to pay a premium for it in markets because they want to know it's a trusted source. So if the medical model isn't actually becoming that trusted source and getting ahead of the curve, and Denmark is one of the most information-rich countries in the world, people are going to seek it out from bad places, right? And they're going to use different technologies to communicate. Now, this is a really interesting slide because communicating with your doctor through email, text messaging, and video, this is on a path that is happening in a very rich way. And if you look at the demographics, you would not be surprised that 35 to 54-year-olds are using text messages a lot, right? Or I'm sorry, emails. But look down here at 55 plus and even 65 plus, where 25% of individuals have been using emails. Now, remember something. Just because 25% at 65 plus are using emails does not mean they're isolated people. They're in their own ecosystem. They have an ecosystem with a provider, a loved one, someone that they are hopefully is taking care of them. It could be an external provider or a nurse practitioner that comes in and helps them. And they're using this digital domain. So sometimes the same person is generating emails from multiple sources. And coming from a system like Kaiser, where 52% of all connectivity with customers are now by email or text message or phone. 52% of all connectivity is now digital in one form or another. The amount of connectivity increases per patient, per person, because they now have access that they never had before. They can ask lots of questions. And it goes up. And so the drivers in this digital transformation, this environment that we're in, is being pushed for competitive reasons. Dr. Google's a competitor, by the way. And it has an impact on people's perceptions of you. Evolving behavior, because people are out there using their own thing. New standards and regulatory and even growth opportunities to be able to expand in markets, and in this case, geographic displacement. And the decision-making has changed. Digital environments used to be the absolute protocol of a CIO. It's not anymore. You may ask your Minister of Innovation sitting in the front row. And you may look up and see that we have chief digital officers, CIOs, even chief experience officers. Have you heard of this before? This is brand new. This like popped up on the radar this year in the surveys. Literally an individual in a hospital, and they have one accountability, and that is to look at the patient experience from end to end, with veto power over processes that are designed to maybe make it easier for the staff, but does not make it easier for the patient, right? And the chief medical officer role, which has grown and grown in the digital space. The C-suite is fully engaged. It is not something that is pure technology play. And when you think about the money being spent in healthcare on a global basis, it is going up. And you can see the difference between the UK, we had 14% penetration of the countries of people using the community, and they're running at 1.3%. They are overstraining their budgets. And the average is about 2% in Europe, right? Netherlands is spending 4% of their budget on IT and on the digital space. And in the US, where it has an average of about 3%, remember that most industries are already paying 6 to 7% investment in technology in their digital space. So healthcare is behind in terms of the resources. Now, the doctors and the EMR, because this has a big impact on change management, and we'll talk about this for a moment. This talks about, on a percentage basis, who has access to a digital record. And I could not get Denmark's, but just take a look at Netherlands close by in the US and look at the two, where 98% of the physicians, and this is from the Commonwealth study, have the ability and report that they're using electronic medical record. And next to it is talking about the ability to exchange summaries with other physicians. So they have a record, and you can see that they're exchanging data between providers, okay? And then it gets kind of interesting, because in the yellow bar, it's saying these are doctors that are reporting that they can email informations and records to their patients, and on the blue bar that they actually are allowing the download of records and information beyond the provider into others. Wow, that's a big disconnect, isn't it? The physicians have the ability to share, but for whatever reason, they're not in some markets. So we'll come back to that in a second. Satisfaction with the EMRs, it's going up, and in markets that are more mature, it's sort of stabilizing, but this has been a big change. Not a big surprise, but this is what's occurring. And you have rollouts of EMRs going on in your regions. Some are very big, some are overseas, some are more locally grown, but it's happening and it's propagating. And it's happening at a moment of massive change, big change. And the provider, believe me, is stressed out about this. They are really stressed out because they're going from the one-to-one relationship, right, to being in a team, right? They've had paper in front of them, they had low use of IT, and then all of a sudden, one day, it changes. Now, let me ask you a question, and this is one of those hands up kind of things. How many of you have a waste bin in your kitchen? Raise your hand. Now, I know everyone, right? Okay. How many of you have it under the kitchen sink? Okay. Now, in my household, there's 2 doors under the sink, right? There's a left door and there's a right door. And for years, the waste bin was on the left side and like cleaning products were on the right, okay? Just bear with me for a second. And so you'd have a wet thing, a paper towel or something, you'd open up the left door and you would toss the refuse into the wastebasket, okay? Muscle memory, you do that. I was away on a trip, and I think a memo came out that I missed. Might have been a consulting study by Deloitte or McKinsey, I don't know. But when I came back, upper management had changed. Yeah. And the cleaning products had been switched to the left side, and the waste bin had been switched to the right. Right? Now, I admit, I am not the sharpest knife in the drawer, but it took me a long time to stop opening that left door and throwing in the paper towel on what were now cleaning products, right? So if you've been a doctor for 25 years, and for 25 years, someone's walked in with a piece of paper moments before you walk in to see your patient, and it tells you right on that piece of paper why they're there or what's going on with them, and there's a little note maybe on the bottom that says, don't forget to ask them about Eric's football game, right? And then the snot-nosed IT brat walks in and takes away your paper and gives you an hour of training on the EMR, maybe an hour and a half if you're lucky, and says, good luck, right? And then the doctors look up and go, gee, it's taken us a long time to get used to this. There's a reason. It's real. It's not fake. And they're having to use this with registries and reminders and things that are telling them what's going on. I mean, do not underestimate it. And the patient is a part of this team who's walking in with the Google stuff and asking if they're looking at that. Wow, this is big change management. This is big change management. This is not small stuff. And it's really, really real. And it gets to the heart of innovation, right? This gets to the heart of change management and innovation that is just pounding away at this medical model that's rushing to keep up with, you know, these handheld computer devices and all the other stuff that we're using, as well as wearables and patient at home and all these components. And the innovation is change. Make no mistake, you are in the change management business. And you're not going to get there incrementally. You will not get there incrementally. We'll talk about that. But 2%, 3% gains versus 5%, this is hard stuff. Because remember, tsunami, wave, money, less people, all that's coming simultaneously. And innovation only succeeds when the interest of these stakeholders, very diverse stakeholders, get aligned with the trade-offs. And they're going to be trade-offs. If you're looking for a perfect world, will not happen. And so it led me to this really cool phrase I saw the other day, which said the electric light bulb did not come from continuous improvements of candles. Nice shot in the middle, right? But that's not what happened. He just didn't go from this candle to kind of a candle and a light bulb to a light bulb. The concept here, of course, is that you've got to get to the light bulb. And the slow incremental changes, it won't get you there because it's a different thing, right? It's in the end a very different ability. So, as you think about closing what we call the O gap, which is the operational gap, we're talking about the GP, we're talking about the government, we're talking about the hospital, and society is all wrapped around the person in a really critical capability and possibility. Got a little formatting challenge. And you will not be successful without remembering this really critical lesson, and this is the second lesson of the day, which is, the third one's the dog, but we'll come back to that. People, process, technology. This is not a technology solution. When you're dealing with change management, I absolutely assure you, no matter what you come up with, we can find a technology to make it work. And if you don't have it, wait 5 minutes and someone's going to invent it. You saw it. Thousands and thousands of apps and thousands of things are being created, right? The people side of using mobile devices, clinical systems, the IT systems, the technology, fine, but the people side of the physicians, the nurses, the providers, the family, the persons themselves, all have to work with new processes in order to bring together what is fundamentally a different operating model. And it's a model that is just like we've seen in e-commerce. It's customer to customer, they're talking, it's business to business, it's business to consumer. All of these things are happening. It is no longer the domain we had before. And it leads me nearly a conclusion to this important formula for you to remember. OO plus NT equals COO. I'm going to have to get a translation for this at some point, but it stands for old organization plus new technology equals costly old organization. Yeah. If you throw technology without rechanging the organization to work and maximize with it, you're going to get this. You will get a costly old organization, right? Because you are sitting in that management place. And if you think for a moment that this is new and that change management and the adoption of innovation, right, is all brand new, this is Machiavelli. And he wrote that nothing is more difficult than to introduce a new order, because the innovator has for enemies all those that have done well under old conditions and the lukewarm defenders of those who may do well under the new. Now, what does it mean in the end? Well, it's classic change management. I assure you that no matter what you go to implement, 25% will say, hell no, won't go. Everything's fine just the way it is. Don't change a thing. That's humanity. 25% are going to say, this is fantastic, best thing since sliced bread, let's go get them, right? And the challenge is to fund, appreciate, and understand that group that sits in the middle who's going to sway the balance one way or the other. They're really the ones you have to bring along. The remaining 25%, the hell no won't go, you'll be surprised. In the long run, they will probably come with you. But this is where the innovation challenge and all of it comes together. So with that, I want to reintroduce you to Bandit. He's the old man. He's a little blind these days, but he's doing well. And I checked in on him about an hour ago, so I know he was okay. I also checked the president to make sure to see if there are any weird tweets going on healthcare. So far, so good. And that's where we are. So with that, let me take questions, and thank you so much.
Så der åben for spørgsmål. Maybe I can start the discussion with one question. I wonder why you talk about consumerism, digital consumers, but most often in the healthcare debate, we discuss how to protect our data, how not to share our data, how not to bring it around all the different parts of the healthcare system. How do you explain that, and how can we bring those two things to get along?
Yeah, that's a great question. Data falls into three really important use buckets, or three buckets, right? There's data ownership, who owns data. There's data usage, and there's data access. So I would encourage everyone, get over the whole data ownership piece. It really can be owned by many different people depending upon where you are. Here, of course, it's the individual, it's the person who owns the data. But data access, I want to be able to see that data and use it, and why. When you think about clinical decision support, and you think about all that we learned and the formulas that go into understanding that new individuals that have these clinical issues now need to have this response and to be able to take all of the external information and extenders, you have to be able to use that information in order really to do your job as a care person. If you're looking at warm handoffs between providers, primary care and secondary care, you need a unified record, and you need to know what the other person did. So I would argue that from a safety and quality standpoint, if the goal is not to share data, that argument is not safety and quality. That is something else. And that gets to the people side of the people, process, and technology. But from a care delivery and a quality standpoint, there is no legitimate or real reason not to have that information shared. Now, that's at the individual person, data information for the good of their care, and doctors cannot operate without it, right? At an aggregated level, it is critically important to protect and de-identify that data, but nonetheless to use it to understand the outcomes, because otherwise we'll never be able to identify how to do things better. And I won't use words like protectionism or things of that nature, because that would be unfair. Of course, I won't even bring it up. But potentially, I would look on the people's side.
Det også muligt at stille spørgsmål på dansk, så vi prøver at oversætte.
Am I standing between you and cocktails? I might be standing between them in cocktail time, too.
At least it's been a long day.
It's been a long day.
Yeah. Any other questions?
Yep, in the back.
Down here.
Yesterday, Rebecca Richmond, isn't there an echo in this? Well,
yes.
Yesterday, Rebecca Richmond briefly mentioned the patients, what they want and what they need. I sort of thought of that distinction during your talk.
Yes.
Because you left the impression that they must have everything they want. And you also, of course, mentioned the funding problem. So there's a dichotomy there.
Yeah.
Can you enlarge on that?
Yeah, it's a great question. So let's put it in the context, and I really appreciate the fact you asked it that way. Patients want, in basic society, the constant, I want what I want it now. And we've seen this happen, and it's driving every component of society. Right, wrong, or indifferent, there's this fundamental expectation on the consumer side of instant gratification, and it's growing. And in healthcare, we have seen a shift from, I am so grateful the doctor's willing to see me, to why in the heck am I having to wait so long? Right? I mean, it's an attitudinal shift. And it's not all the way over on one side or the other, but we can see the shift occurring. What we're recognizing, and this is really what I'm trying to get across, is that it's not a light switch, which means you have to shift entirely digital to the next day, but it is a critical part of how people communicate, connect with each other, and have expectations. And when you think about the cost and the extending of medical systems, beyond building brick and mortar and one patient at a time from an encounter standpoint, the tool sets that are available to us in the digital space to reach individuals and personalize individuals complement and also attach themselves to what individuals are learning to expect from society as a whole. And if those two aren't connected and they're not together, people will find a way around it. They'll use Dr. Google. They'll figure out their own diagnosis, right, wrong, or indifferent. They're less patient than they used to be. So it's not one or the other, it's how do you blend them together and take it into account as we change and grow. Does that help? So? That's better than a no, you know.
Hi, my name is Sophie Anderson. Thank you for touching on the difficulties on new EMR systems and how we do changing management. I think you yourself has a lot of experience in implementation of especially EMRs or know a lot about it. Could you say a little bit about how you think the 25% is who really feels that they are being overrun by the technology?
Yep.
You know, because I think their feelings are real. I mean, and you need to do something about it.
Yep.
Because the other 25% who is happily and jumping around and like that are not, you know, they are sort of provoking the other ones.
Right.
So
You're absolutely
could you
right.
touch on that?
Yeah. there's a moment in time where you recognize that your healthcare system has changed fundamentally because of the use of information in EMRs. It is wasteful and extremely hard to maintain a dual system, right? You can't maintain a paper system for 20% or 25%, and everyone else is doing everything else at 75%. That of course won't work. The emotional part about that transformation, it is very real, and it is really emotional. And to be frank with you, some physicians will look up and say, I'm not going to do this, and you know what, it's time for me, I can't change, I'm going to go do something else. It happens. It's tragic because you lose tremendous value and you lose tremendous experience, right? Which can be so important to young physicians and others that are coming along, and you don't want that to occur. So how do you support them, right? How do you come alongside? And doctors hate feeling, silly. They don't like to be in the position of feeling they don't know the answers. And there's part of that too, because it's a generational component as well. I have to be the all-knowing individual. The best I've seen is just that recognition. And so we filled the hallways with individuals that had pennies, jackets, vest, colored vest, right? And during transformation, and this is just something we did in the hospital in particular, in the clinics, we had 3 colored vests. You had a green vest, which is someone who was an experienced user, and you could call them over at any time to help you figure out the next step. You had a yellow vest, which was someone who could fix a printer connection, or make sure that the monitor was up and running and was doing that. Not a super user, but a connecting bunny, if you would. And then you had a few people in red that were supervisors, right? And it doesn't take a lot, but at least you knew the color that you were looking for if you needed help. Just support the best you can. Recognize that extra training has to occur. People have to be able to vent. So getting the doctors together weekly, even every night if you have to during the transition, and let them do it. But the reality is you have to give them all the support you can, but with the recognition that some just won't make it. But of course you're respectful, because these are amazing people with amazing experiences, right? And you just hope that they can come along for the ride. In my experience, of that 25%, 80% make it. And some of them become your most ardent supporters. And then some don't. But that's a small percentage in the long run. But don't fool yourself into thinking you can maintain a duality. You've got to make a strong cutover at some point, or you'll just absolutely bog down your entire system.
Thank you very much for your interesting and very much inciting talk. I have 2 questions. The first question is about the data sharing, When I visit a GP, there is a kind of confidence between him and me, or between her and me. And I know the data he acquires through the treatment belongs to me. So if he passes on the data into the system to somebody else, then according to my view, that's a breach of confidence, which makes me, I'm not talking about myself, well, let's put it another way, one sees it as a breach of confidence.
Okay, yeah.
Okay, how do we go about it? Mm-hmm. This is the first question. And the other question is, then if you have the data, you said data owners and data sharers and so on. If the data is just floating, what happens is that those who know how to exploit that data, they start commercializing all those things, and all of a sudden you have a letter or an email from somebody telling you, according to the genetics you have, you were exposed to this or that very dangerous sickness or illness. So we will give you some kind of medication which will cure you, you know. So there is a danger involved in these things, you know. So we have to protect the data we have, and how do we go about it? Thank you.
Great. So you've got 2 or 3 things wrapped in on that scenario. So let's take the first one. When your information goes into a central repository, it is not set up so that any person anywhere can go and see it, right? There's normally very much of a hierarchical reference where people are allowed to see it only if they are involved in your treatment. And there are logging principles that sit inside every EMR that allows you to look and see who had access and looked at your data. And there are security principles in every single EMR that are designed to be set up so that doesn't happen unless a person does have permission, and you know who it is who breaches that. And that's very critical. Just to your point, this isn't about your physician taking your information and putting it on their system for the world to see. It's about having it available so that if you wind up in an emergency room 4 hours later, the latest information about you is available to that attending physician for your quality care. And 4 hours later, that can happen because you can walk into your physician's office with a little bit of chest pain, and they may look at you and say, that was a bad casserole last night, you know, because I'm not seeing anything in particular, and it turns into, you know, a cardiac infraction. And so you may wind up, and they need to know that you were just there, and they need to know what medications you were on, and are you taking aspirin, whatever the case may be. So that relationship inside the EMR and where that gets sent, that's very important to be locked down. The second part you're bringing up is about data aggregation. And again, I want to stress de-identified data. Now, de-identified data means it does not go to a large-scale repository that people can access for research and stuff without certain elements being taken out. And when you look at the way that is done today, it's not just a question of, well, let's remove the name, because people can back into that, right? The UK figured this out a long time ago. Their postal codes, right, are narrowed down to no more than 6 houses. Right? So I can look at a postal code, and it's one of 6 houses. And if the demographic information is sitting there, I can pretty much guess which of the 6 houses it is, and therefore I'll know the person's name. So there are actually algorithms that large data repositories have to jumble the information from a de-identifiable standpoint, but make it such that researchers can't back into it. And those codes change on a regular basis, and that's a standard practice. The last part you brought up is really an interesting one about genomic data. And it is really hard to de-identify genomic data. It's a bit like looking up and saying, de-identify my thumbprint, right? So the genomic data problem is definitely one where the algorithms are being developed and have been developed and are getting more and more sophisticated to be able to look at the strands themselves at the 21 mark all the way down to 33 and even further depending upon secondary or tertiary data when you're looking at a genomic strand. And it's very personal. And the question there is one of access, because the data repository and the information in it is rarely connected directly to the patient data. It's being held and reserved in most cases in a secondary offshoot, just for the reason you brought up. And so we don't have clean answers on the genomic piece yet. And right now it is being used person by person, very deep runs, because you're usually trying to solve a very specific problem, right? So that is one. That last one you mentioned is the one that would keep me up at night a bit. But the first two, I am really confident that the right answers are already in place. On top of that, I would just simply say vigilance reinforcement and constant update of the process is to ensure that, right? You got to do the cross-check.
Thank you so much, Hal, for sharing your insights into not only digitization and disruption in general, but also and what interests us, how will it affect healthcare in specific. Thank you very much.
My pleasure. Thank you all so much. Thank you.